Hello, everyone. My name is Alexander Arders. For those of you who don't know me, I've been running with Warwick for about 4 years now. Started back in 2017 while I was finishing up college. And since then, I've been kind of intermittent here, back and forth, working as a basic with them. And I just recently finished PA school, and I'll be taking a job up at Hershey Medical Center in the emergency room. So let's get started here. So I'm going to be presenting on SIRS, sepsis, and shock. And it's going to be geared towards an EMS viewpoint and what we're going to be looking for from that standpoint. So I'm going to stop my video here. Let's move on. Okay, so let's go through an outline, kind of what we're going to be accomplishing today. So we're going to go through some definitions. I want to define sepsis, SIRS, and let's just talk about all that. Epidemiology, so how frequent, how often, how big of an issue is sepsis? Etiology, what are we looking for? What's causing it? The pathophys, what's really going on in the body? The history and physical component of when you actually see the patient, what you're going to be asking, what you're going to be looking for. Some screening tools, some diagnostics and treatment, and also we're going to go through some cases at the end. So some definitions here. Start out with SIRS. Not everyone knows what SIRS is. Maybe you've heard of it, maybe you haven't. So systemic inflammatory response syndrome. So this is basically a dysregulated immune response inflammation. It's not related to an infection. So it will happen with an infection, but it can also not have. Common things you'll see without a present infection is pancreatitis, venous thromboembolism, burns, even in surgery as well. So think of this as like a pre-sepsis, or what you would call the abnormalities in the vital signs before there's a confirmed or suspected infection. So these are the criteria down here. This is taken directly from online. So the ones I highlighted here are what's going to be seen mostly in pre-hospital: the temperature, heart rate, and respiratory rate. So that's going to be the big things to look out for there. And you need 2 or more of these criteria to meet the SIRS. So let's go to sepsis. So SIRS, what we just talked about, and then plus a documented or suspected infection. And then septic shock, that's when we start seeing the organ failure and tissue hyperperfusion. That's when we're getting, we're starting to decompensate. Big ones here, especially pre-hospital, is going to be seen. It's for urinary tract infections and also pneumonia. Big killers in the elderly. Epidemiology. So how frequent is this? How often is this? So it's pretty common. We see a lot of almost 2 million cases a year in the US, and the mortality rate is relatively high. So even in sepsis alone, 18%, that's high. And then we're almost at 50% if we get to the shock stage. So recognizing this early is it's increasingly important. And it's a top 10 cause of death. We're seeing over 200,000 deaths per year. So etiology-wise, bacteria, it's the most common organism. It's going to be the most common organism we're seeing. And like I said earlier, pre-hospital-wise, the pneumonias and the UTIs, that's going to be the most common thing you see. And that's more or less the most common infections seen in the hospital and just everywhere. That's causing patients to go septic. So we're talking about community acquired. We're thinking these are living at home or in a nursing home. And then recent childbirth, STDs, endocarditis from IV drug use. These are all community acquired type things. Hospital acquired, we're either thinking that they were recently discharged or they're an inpatient there. So most likely we would see them as a recently discharged patient, whether that be on a transport or rather going out for a 911 call a few days after they were discharged from the hospital. And then non-bacterial, it's going to be fungal and viral. Fungal is going to be more recent travel to endemic areas, and viral, big ones that can cause sepsis is flu and also cytomegalovirus, CMV. So the pathophysiology, what's really going on inside of our bodies at this time? So we're having an inflammatory stimulus, just like from the last page, we saw the bacteria, UTIs, pneumonia, and it's triggering a pro-inflammatory chemical mediator response. And we're actually being hypercoagulable in this state. So increased risk of blood clots, and actually can cause these microthrombi. So there's multiple other chemical mediators. They're releasing different hormones and chemicals within our body, causing dilation of blood vessels. That's what's causing a hypertension, and we're shunting blood away from our essential organs. And then we're also going to increase cardiac output by causing the tachycardia. That's why we see the heart rate getting over 90, 100. And then a combination of these microthrombi and the hypotension is what's decreasing the oxygen delivery to these end organs that we have. So the end organ damage that you hear with sepsis, septic shock, the big things we're going to be looking at here, I categorize the different organ systems here and the different major organs that we're going to be seeing. So with liver, we can see some jaundice, cardiovascular. That's going to be the big one. We're seeing the decreased blood pressures, poor capillary refill, and skin changes, respiratory. We're going to see increased respiratory rate. And then for capnography, we're going to see low end tidal CO2. It's going to be below 25. There's going to be a normal waveform though. So a good thing to think of for end tidal CO2, it's representing a buildup of lactate in the body, causing acidity. We see this a lot we talk about it a lot with athletes, lactic acid buildups. You hear about the sore muscles and whatnot. But that lactate, as it builds up, it's causing acidity in the blood. And what the body is trying to do is blow off the carbon dioxide, which carbon dioxide is converted to carbonic acid, which causes acidity in the blood. So more carbon dioxide, more acidity in the blood. But now that we have lactate in there, we're acidic. So we're trying to blow off the CO2 to compensate, to get back to our physiological level, internal pH. So renal, we're going to see decreased or even no urine output. GI, we're going to see abdominal pain. Decreased bowel sounds is a big thing to look for. Listen with the stethoscope, or are we rarely hearing any tinkling sounds within the bowel in the 4 quadrants? And then also something to note for is no bowel movements at all. Patient hasn't passed about bowel movement in multiple days. Heme, so we're going to get a transient platelet drop, so that can cause easy bruising. Recent easy bruising. And then CNS, central nervous system, we're going to see decreased or decreasing GCS. So altered mental status is the big one there. Now moving on to the history, this is going to be extremely important. This is what we're going to gather from the patient out in the field. So the history of present illness, what's going on? Is there cough, urinary symptoms? Have they had a fever? Have they been sick recently? Have they had a dental procedure, recent travel? Are they immunized? And big thing is going to ask the family and nursing home staff if the patient's unable. Getting this important history is going to be, it's going to, sorry about that. What I was saying was getting this history is extremely important. And then moving on to the past medical history. So for immunocompromised people, diabetics, a history of MRSA infection, these are all going to be situations that might make them more likely to proceed to sepsis or have an infection that could go to sepsis and then shock. Social history, IV drug use, that's going to be big there. And so these are just some questions to ask, some examples of questions to ask. We want to try to encompass and determine the length of symptoms here. So like I said, I'm going to keep drilling it in. It's urosepsis and pneumonia. They're major killers in the elderly. So, and with really frail and elder patients, we may not see a fever, and they may have non-classical and non-typical symptoms. So something to watch out for. Moving on to the physical exam portion after we've gotten the physical. So full body physical best you can. So lungs, heart, abdominal, skin, neuro. Lungs, pneumonias, heart, are we thinking murmurs? Murmurs, that can be, if it's a new murmur, that could be thinking a endocarditis, especially in IV drug users. Absent bowel sounds. Is there a widespread cellulitis, or there an obvious abscess somewhere? And then altered mental status, especially. Indwelling catheters, that's a high risk for having urinary tract infections and then leading to urosepsis. So especially if they have an indwelling catheter, look at the urine. Does it look cloudy? Does it look not right to you? And also note the output and the time estimation. Have they not had any urine output in the past 24 hours? That's really important. That their kidneys aren't functioning. You need to note that. And as we said here, decreased urine output is a sign of acute kidney injury and overall poor perfusion. Also, when we're looking at the skin, we're looking at cap refill, pallor, is there skin changes? Is there any indwelling caths or ports for cancer patients that are receiving chemo or other indwelling IVs, PICC lines, whatnot? So vital signs, these are going to be the big ones. Everyone's getting a set of vital signs right away. So this may be the first thing that jumps out to you. So fevers, tachycardia, tachypnea. Those are going to be the big ones. Hypotension. So here's the classifications for the hypotension. So we're looking under 90, mean arterial pressure. That's going to be under 70. And big thing, we're looking at systolic here mostly. And then over 40 millimeter drop, or are we 2 standard deviations below the normal age baselines? Obviously, pediatrics are going to have a lower blood pressure at baseline. Older patients might be higher. And the mean arterial pressure, that is a better representation of overall perfusion in the body, as opposed to just systolic blood pressure as a whole. So a couple screening tools that I want to mention here. We can use pre-hospital. So the QSOFA, quick sequential organ failure assessment. This is used as a mortality assessment as an inpatient, but there is some diagnostic capabilities in the pre-hospital setting. So respiratory rate over 22, altered mental status, and systolic blood pressure. Those are 3 easy ones that we're going to be able to see just getting a basic physical and also vital signs with them. So more than 2 give a higher likelihood of sepsis. This next one's more involved, may have less utility in the field, but has a lot more within the hospital itself. So there's 7 different parameters. So we're looking at respiratory rate, temperature, oxygen saturation, systolic blood pressure, heart rate, AVPU for the mental status, and then the need for supplemental oxygen. So now, depending on how many of these criteria we meet, we go to low, medium, high risk. And this is when it's in the hospital, it's used to detect clinical deterioration in patients. So here's just an example. Like I said, it's more involved, but these are the different categories. This is taken from a MD Calc, and I'll go over that. It's a clinical resource tool you can get as an app on your phone. So this is definitely just looking at the respiratory rates, saturations, temperature, blood pressure. Looking at the heart rate here, the AVPU, and whatnot. So again, that was the news is a little bit more involved than the QSOFA, but still, just know that there is several diagnostic tools that you can use out there. So moving on to the pre-hospital diagnostics that we're going to use, getting an EKG on someone. Are we in an arrhythmia, or is there any ST changes looking for any sort of ischemia because of poor perfusion? Are we tachy? Are we Brady? Blood glucose, it may be elevated actually in early sepsis, septic shock. So something to note for. And then we're going to look at capnography. Like I said, we're looking for that under 25 number and when normal waveform. Blood draw too. This is going to be great if the hospital accepts them. Obviously, I know LGH doesn't accept them, but the heart will. So things to look out for here is they're going to be getting blood draws as it is because they need to do blood cultures. So if the hospital will take them, it's going to be worth that extra few minutes to get those. Speed up the process in the hospital and better treatment for the patient. Oxygen saturation is big, and then mean arterial pressure. We have the benefit that the monitors do this for us. And since every BLS truck also has a monitor on, we're getting this measurement there without having to do any math calculations. Pre-hospital treatment now. You're going to hear it all the time. So ABCs and early activation. If you suspect it, you need to activate the system. And a little bit more in depth now. So we're going to consider intubation, especially if we're not protecting the airway. This is big if we're not. If their mental status is to the point where their airways is compromised. So try to get at least 2 lines in if you can. The bigger the bore is going to be better for dumping fluid in if we need to. So IV fluid resuscitation, that's going to be our first line treatment for hypotension. And even if they aren't hypertensive, we might want to give a bolus. A 250 bolus is recommended, even if they're normotensive and you suspect that, oh, this might be heading towards sepsis. So you want to get those IVs established, and you want to get a bolus in regardless. And then obviously we're going to be watching out for CHF or previous diagnosis of CHF if we're going to be running high levels of fluid in. But we're basically going to be giving boluses, repeated boluses, until we can get them into a better blood pressure range. So obviously oxygen if needed. If they're in the high 90s, there's no reason to put oxygen on them. And then, but be ready to give vasopressors too if they're not responding to these fluid resuscitation. We might need to give vasopressors. From my understanding, paramedics, they have the epi and they also have dopamine for these vasopressors as needed. A little bit of discussion on vasopressor. So norepinephrine, that's a gold standard for sepsis. It's in the hospital. That's going to be their first line if there's no contraindications. But that being said, paramedics don't carry this pre-hospital, and the two that I'm aware of is dopamine, epinephrine. Just some things to look out for. Dopamine increases heart rate, stroke volume, cardiac output, mean arterial pressure. Great. But risk of tachyarrhythmias with that. Epi, increased heart rate, cardiac output, mean arterial pressure. Great. Can also cause these tachyarrhythmias. So, and it also, a unique thing is it can falsely elevate lactate levels because we're metabolizing with the skeletal muscles. So lactate levels are going to be monitored in the hospital. So if we're giving epi pre-hospital and then we're getting a lactate in there, it's something to note that it could skew this a little bit. Obviously, if we need to give epi, we give it, but it's something definitely to note. Can also decrease gut perfusion because we're constricting the blood vessels and they cause ischemia. So just 2 things that I noted here. So it's obviously what you're more comfortable with and what the patient's going to need. So they have a known arrhythmia like an AFib, might want to be more cautious giving the dopamine. And may want to consider not giving epi if they're having severe abdominal pain and we're thinking, oh, they have poor perfusion in their gut right now. So just things to look out for. Another thing to watch out for is different patients in their history and some people that can cause you trouble. So the elderly and frail, they are known for having atypical symptoms, infection. They're not going to get these high spiking fevers that we'd see. They may not have a fever at all. Patients on chronic steroid treatment, do they have some sort of autoimmune where they're on prednisone? This is going to blunt the immune response, and we're not going to see the fevers and the compensation methods here, like in the tachycardia because of dropping blood pressure. Younger patients, they may have prolonged tachycardia and then they're going to have an acute drop. They can crash very quickly and very hard. And then patients with a cardiac history, think, okay, are they in a beta blocker? They may not be tachycardic because their medication, their heart rate can't get to a certain level. They may not be over 90, over 100 because of those beta blockers that they're taking every day. And also think of a chronic hypertensive patient. Their normal blood pressure may be running in the 160s, 170s on a baseline daily. They've been living at that for years. If they drop into the 110s, 100s, they may not be classified as hypotension per se, but they're going to be having these symptoms of poor perfusion because their body is just not used to it. So let's sum it all up here. So recognition and activation, that's going to be paramount to everything. We got to know our protocols, know your meds, the vasopressors. If you're not comfortable with them, review them, know when to use them, and be ready to use them if you need to. Watch out for those black sheep we were just talking about, these patients that might have atypical symptoms and they may have a quiet sepsis brewing. And like I said, first line for hypertension, push the fluids. That's what they're going to do in the hospital. They're going to keep bolusing until we can get them in a regular normotensive state. All right, so some useful tech tools that I was talking about. So MD Calc's free app, I use it online. There's a lot of people in the hospital that use it. You can also use it on a laptop as well. So they have different equations, scores, algorithms, guidelines for many different things. So QSOFA and the news criteria are both on there. So another gadget for the truck, possibly. So a new gadget might be a finger stick lactate monitor. So it's seen a lot in elite athletes that use this. They monitor them, and same deal. You're going to prick the finger like with getting a blood glucose, and we're looking to have that goal of under 2 millimoles per liter. So it's beneficial in the ED to know the lactate level, because they're going to fluid resuscitate them. And especially before pre-hospital, if you're going to dump much of fluids in them, you're going to dilute this number. So it may be something that you want to have on the truck. If you're suspecting sepsis, you can get this before giving them fluids to say, this is what it was. When you get to the ED, this is what the patient was like before I gave fluids. So from what I found, it was, they might run $200 to $400. And this is just, like I said, just when sepsis is suspected. This isn't going to be a normal vital sign on a patient. This is going to be highly suspected of sepsis. Am I going to be activating code sepsis on the way to the hospital? So just discussing lactate, like I said earlier, it's a buildup of waste and it's converted to lactic acid. That's causing this overall acidosis in the patients. And then, like I said, they would try to burn off or try to blow off the CO2 to decrease the acidity and raise the pH. So I would check with your medical director and then also the PA protocols. I did a brief look and I couldn't find anything specifically that said you couldn't have these lactate monitors. And I know that some EMS companies across the country do have this. So a change you might see, so pre-hospital antibiotics for sepsis. There are some studies out there that show a major benefit to administering antibiotics pre-hospitally if sepsis is suspected. So it's given for these red flag symptoms. This is going to be the patients that meet those SIRS, meet those QSOFA criteria. There's a really high suspicion of infection, whether they have indwelling catheters, they have an obvious sounding pneumonia in their lungs and whatnot. And it would require blood draws prior to administration. So if we're, just for instance, if you were going to LGH and they don't accept your blood draws, this could cause some issues as well. So not many EMS systems have rolled this out, if any. There was a pilot program in PA actually back in 2013 in Marple Township. It's a small area outside of Philadelphia. And it showed great benefit, like I was saying. And red flags are these blatant vital abnormalities. And I don't necessarily think that these antibiotics are on the cusp or near passing to come out. But if sepsis deaths continue to rise kind of how they are, then it could be definitely brought up in discussion. All right, so now let's transition into some cases here. I'm going to read this first one here. So EMS is dispatched a local residence, 20-year-old female, foot pain. Spent the weekend on the beach, cut her foot on some glass. Over the past 3 days, her foot's become increasingly painful, developed a fever that hasn't responded to Tylenol, conscious, alert, and weak. A little bit hypertensive there. Respiratory rate's a little high, blood pressure's a little low. And we don't, for whatever reason, we don't have a temperature. So the big thing is, what are we thinking immediately after getting this set of vitals? Is the history suspicious? Something's not right here. Why do we have this 20-year-old patient has these abnormal vital signs? She has a possible infection. We have a laceration on the foot, walking on a dirty beach. So the history is concerning for contaminated wound. So moving on here. Focus assessment of the patient's foot reveals a 1-inch lac, no evidence of bleeding, but it is swollen and painful. Since the patient's not in acute distress, the medic suggests that she go to local urgent care in the morning, and they obtain a refusal. Next morning, medics are dispatched to that same urgent care for a transfer to a local hospital for hypertension. Upon arrival, the medics see this patient. She's hypertensive, tachycardic. She has a temperature, and she's transferred to the local ER. and the medics infused 500 milliliters of normal saline on ride. Okay, so definitely something is not right here. She's worse from yesterday, and now definitely we're heading that wrong direction. We're getting the heart rate's up, blood pressure's down, and now we have a confirmed temperature here. So it was reasonable to have that refusal on the first day. What we don't know in this scenario is who called. Was it the patient's mom? Was it some other family member that was concerned? And then the patient was in a stable mind, and it was very reasonable for her to sign a refusal. So I don't think that was a wrong move. Obviously, in retrospect, you see that she started to decline rapidly. So the refusal wasn't the best option, but I don't think you would be wrong in obtaining that refusal early on, especially with the current wait times in the hospital. You know, she might have been there for 5-6 hours for something simple like that. So again, just use your clinical judgment on that first time you see the patient. Even though she was fine, something was brewing. So at the emergency department, they get the blood cultures, ibuprofen administered for fever, antibiotics for cellulitis from that wound. Okay. So she continues to be hypertensive. She needs to go to the ICU, intubated, despite blood pressure, support, and aggressive antibiotics. She dies within 24 hours. So the young patient is a description of the septic shock in her wound. In 2 days, this patient went from perfectly healthy, a young adult, to septic, and now she's deceased. So like we said, these young patients, they can crash quickly. All right, let's go to case number 2 here. So I'll read it out and then I'll let you think about it for a second. So crew arrives to find a 68-year-old male complaining of shortness of breath. Shortness of breath began after waking 6 hours earlier and is progressively getting worse. Since lunch, he's been unable to ambulate without becoming significantly short of breath. He hasn't been feeling great over the past several days, had a productive cough. Occasionally he's woken him from sleep. All right, so let's look at this history here. Hypertensive MI, hypothyroid, medications. He's on some blood pressure meds, something for his thyroid. He's on blood thinner too. Vital signs, yeah, a little bit abnormal there. So give it a hot sec. What's your plan here and what's your treatment? What are you thinking? Well, first of all, I don't like the shortness of breath and the cardiac history. That's important. Are we heading in the route of an MI, STEMI? What are we thinking here? And the vital signs aren't so great. The end tidal CO2 isn't below that 25 range, what we're looking at, but we're still on the low end of normal. So it's something to be suspicious of. Respiratory rate's high, blood pressure is borderline low, heart rate's high. Oxygen saturation is not good. And we got an elevated glucose there for sure. Temperature. So our plan here, what's the treatment here? So the oxygen, our sats are low. We're going to need IVs, blood draws if we can accept, if the hospital's going to accept, IV fluid bolus. If we have that point of care lactate, we'll get that. And then sepsis alert. This is definitely something, a patient, we want to activate sepsis. We're having these acute onset of symptoms and we're having changes in the vital signs that are suspicious of heading in that direction. So case number 2A. So this is a little bit related to the last case, but there's another point I want to discuss here. So let's go through this one. So crew arrives to find a 56-year-old female, sudden onset, high fever, general malaise, myalgias, and a non-productive cough. She awoke this morning feeling normal, and right after lunch, she progressively worsened rapidly. She's been having a fever that hasn't been responding to Tylenol. So her history, let's take a look. She got type 2 diabetes, note that, okay. She got an allergy, penicillin, naproxen, medications, diabetes, and the high cholesterol, okay. So a couple things that I'm looking at right here. I don't like this acute onset of symptoms again. Remember that pneumonia, UTI, it's the most common causes to go to sepsis. So diabetes, like I said, it's something to note here. Higher risk of infection, and so it's something suspicious. We want to look at this. All right, so we get those vital signs, take a look, and take a minute to think about what we're going to do here. All right, so those vital signs actually don't look that bad. She's at 100. Okay, so right on the line of tachycardia and normal rate there. But look at her fever. She has a 103 fever, and heart rate goes up a little bit when we have a fever. She wasn't on any beta blockers, so it's not like her heart rate's being capped at a certain level. Heart rates or her respiratory rates at the high level normal, that's still okay. Oxygen saturation's fine. Glucose, yeah, a little bit high, depending on if she just ate or whatnot, but she is diabetic. So, and her end title's perfectly normal as well. So what's our plan? Are we going to activate code sepsis with this patient? What do we think? So no, I don't think this is warranting an activation. This is most likely a case of the flu. Big thing there is the myalgias and the rapid onset. You can have rapid onset with pneumonias and whatnot, but they tend to be more of an indolent and slow growing. So it's very important to differentiate between flu and other illnesses like a pneumonia, like with the last patient we saw. And the big thing that was different between this patient and case number 2 was the vital signs. The vital signs are great in this one. They're totally fine. So this is an instance where we can use that SIRS definition and QSOFA screening tool to see if they qualify as sepsis. SIRS is right at 2 for this patient. So again, we're right on the line, but if you did the QSOFA, it says she probably doesn't have sepsis. Look at the clinical picture here. These muscle aches, and there's no production with the cough. She's not coughing anything up. You could ask some questions like, has she been around anyone sick? What's her occupation? Is she a teacher? Is she a healthcare worker? Could she have been exposed to someone? Has she been vaccinated for the flu this year? If we do this early on, it saves some time and the patient money if we don't activate sepsis here, because we recognize, oh, she's actually probably fine. And if she did have some early sepsis before the vital signs, she's going to be getting to the hospital regardless. So I don't think at this time it's risk activating code sepsis. Okay, so the last one here. So EMS responds, local nursing home, alter mental status. Patient's a 72-year-old male who was admitted to a skilled nursing facility for rehab following a total hip replacement. Staff says he's become altered this afternoon. He's been unable to ambulate. He was admitted to the facility last night, and very little information is known about this patient yet. We've all seen it, different nursing homes, different level of care, different quality of staff per se, but we'll keep moving on here. So history, okay, hypertension, AFib, type 2 diabetes. Medication, he's on amiodarone and warfarin, note that metformin for the diabetes. Okay, he's a little bit heavy for his size. So what do we think of our first thoughts here? So he was just in the hospital. He had major surgery. We're showing some red flags, possibility for infection here, of course. We're in that hospital-acquired category for infections. And diabetes, so we're having increased risk for infection as well. Take a look at these vitals and think about what your plans, thoughts, treatment, and if we should activate them. I'll give you a minute. So we definitely have some red flags here. He's tacky, he's hypotension, he's a low temperature. Remember, everyone thinks of fever, and that's going to be a more common one, but in the SIRS criteria, it's above 100.9 or below 96.8. So this is going to be a low temperature. He has a low end-tidal CO2. He has high glucose. He's diabetic, but that is much higher than you would think to be running, a 280. He has that swollen and red surgical incision. And so if you're a BLS truck and you go out for this, you're going to want to call a medic. We're definitely seeing a lot of abnormalities with the vital signs and the altered mental status and whatnot. So it's definitely concerning. This patient is heading in the absolute wrong direction. So what are we doing? What are you thinking about treatment-wise? So IVs, high volume fluid. He's hypotensive. He's going to need it. Consider pressors if we have no response here. This is definitely someone we're going to activate code sepsis with. Again, blood draws and point of care lactate if applicable. His oxygen saturation is fine at this point. He's 96%. There's no reason to put high flow oxygen on this guy if he's not dropping below the 95 range, 94. So you might want to hold off on the oxygen at this point, but if he starts to trend that way, you can put some on him. Very hypertensive. We're going to need to correct that. And definitely looking at this septic shock here with the altered mental status. Thank you everyone for listening. This has been great to present to you guys. I hope everyone's having a great skills day. And it's been an absolute treat to be a member of Warwick Ambulance over the past few years. So best of luck. If you have any questions, feel free to reach out. I have a list of the references I have here. And most of you have my contact information, if not share. And I can also provide Chris with my email if anyone has any questions or wants a copy of the presentation for further studying and whatnot. So just reach out, and thanks, guys.